Okay, let's unpack this. Imagine you're hitting the books, maybe revising for the MSRA, specifically tackling acute interstitial nephritis, AIN, and you're staring at a stack of revision notes.
Yeah, happens to us all.
Exactly. And you need the absolute essential points to jump out, stick in your brain, and be ready for recall.
Mm-hmm.
That's basically our mission today. We're taking the specific revision notes you've shared with us on AIN and doing a deep dive to pull out exactly what you need for, well, effective revision.
Right.
Think of this as your focused, high-yield audio companion for really nailing this topic.
Absolutely. The goal here is, like you say, to cut through the detail and just highlight the core concepts and facts from these notes. Make the information digestible and genuinely useful when it counts.
Perfect.
We'll structure it just like the notes do, covering, everything from the basic definition right through to potential complications.
Yeah, I like that. Taking these notes and really pinpointing the critical insights. Let's find those golden nuggets together.
Precisely. By going through the material systematically, point by point, and emphasizing what the notes highlight as most important, we can hopefully clarify and solidify your understanding.
Okay, let's jump straight in then. The absolute basics from the notes. What exactly is acute interstitial nephritis? The definition says it's an inflammatory kidney disorder. Which part of the kidney are we actually focusing on here?
Right, so the notes are quite specific. While nephritis sounds broad, AIN really zeroes in on the renal interstitium.
The interstitium, okay.
Yeah, that's the tissue and space outside the glomeruli, the kidney's main filtering units.
Ah, okay, so not the filters themselves.
Exactly. It's a key distinction from, say, glomerulonephritis, which affects the glomeruli. The notes briefly mention that contrast.
Got it. So it's the surrounding tissue getting inflamed. And the notes really hammer home something about why it gets inflamed, right? The mechanism.
We do. A core concept highlighted is that AIN is typically an immune-mediated hypersensitivity reaction.
Immune-mediated hypersensitivity.
Okay. Yeah, that mechanism is pretty fundamental to understanding how many of the causes actually trigger the condition.
And why is understanding this distinction and the mechanisms so important when we're thinking about acute kidney injury, AKI?
Well, because AIN is actually a significant player in AKI.
Yeah.
While other things like acute tubular necrosis or glomerulonephritis cause AKI too, the notes state that AIN accounts for a pretty substantial percentage, maybe 15 to 20% of AKI cases.
15 to 20%, wow.
Yeah, and it's very often linked to drugs. So recognizing AIN as a distinct cause of AKI means, to look for specific triggers and presentations, which might differ from other AKI causes.
That makes sense. If it's responsible for that many AKI cases, especially the drug-related ones, then knowing the causes is absolutely crucial. Let's dig into the etiology. Where does AIN come from, according to these notes?
So the notes list several key categories. Medications are probably the most prominent one, a big one.
Right.
And we're talking about really commonly used drugs here. The examples given are antibiotics, NSAIDs, proton pump inhibitors like omeprazole, and diuretics.
That covers a lot of ground in prescribing, doesn't it?
It really does. You need to be aware of those.
Definitely. What other sort of big buckets of causes are mentioned?
Infections are another important category mentioned. The notes list both bacterial and viral culprits, including things like Epstein-Barr virus, Hantavirus, and HIV.
Okay, infections too.
Then you've got autoimmune diseases, things like systemic lupus erythematosus, SLE, and Sjögren syndrome.
SLE and Sjögren's, right. And I think I saw systemic conditions mentioned as well.
Yes, sarcoidosis is listed under systemic causes. Now, the notes do briefly touch on causes of chronic tubulointerstitial nephritis, or CTIN, long-term exposure to things like 5-ASA, lithium, heavy metals, certain cancers, genetic disorders.
Right, but that's chronic.
Exactly. But for acute interstitial nephritis, the focus from this material is clearly on those more acute exposures. Drugs, infections, maybe an autoimmune flare-up, and sarcoidosis.
Okay, sticking to the acute picture for this deep dive. So given those causes, are there specific factors that make someone more likely to actually develop AI? And the notes list some risk factors, don't they?
They do, yeah. Beyond just being exposed to a potential cause, certain things seem to increase vulnerability. A pretty straightforward one is recent exposure to those known causative medications or any other substance known to be nephrotoxic.
Which links straight back to the causes we just talked about. Makes sense. What else?
The notes also highlight a recent start or an increase in the dose of a medication.
Ah, the timing or dose change.
Yeah, exactly. It ties into that hypersensitivity idea. Sometimes it's the new exposure or maybe a higher dose that tips the balance and triggers the reaction. And also if someone has a history of drug hypersensitivity reactions in general.
Like other drug allergies.
Yes, they're listed as being at higher risk too. It fits the immune-mediated picture.
Okay, so a history of allergies is a bit of a red flag.
It seems so. And perhaps predictably, having one of the underlying infections or autoimmune diseases or systemic disorders we discussed also puts you at higher risk.
Right.
So when you're taking a patient history and thinking about potential AIN, these risk factors essentially become questions to ask, have you started any new drugs recently?
Yeah.
Any dose changes? Any history of allergies or autoimmune conditions? Framing them like that can be a decent memory aid.
That is a helpful way to think about it, turning the risk factors into clinical questions. Okay, let's get into the how now. How does this inflammation actually damage the kidney? What's the pathophysiology described in the notes?
Well, the mechanism, as the notes explain it, varies a little bit depending on the cause. But for the most common type, which is drug-induced AIN, it all comes back to that immune-mediated hypersensitivity response we mentioned.
So the body's own defenses are actually causing the problem here.
Precisely, yeah. When the kidney is exposed to whatever the triggering agent is, the immune system gets activated. This leads to inflammatory cells, particularly lymphocytes and sometimes eosinophils, infiltrating the renal interstitium.
Right, they flood into that tissue.
Exactly. And it's this infiltration and the resulting inflammation that damages the renal tubules and impairs kidney function, leading ultimately to the AKI symptoms.
And if it's infection-related?
If it's infection-related, it might be the direct effect of the pathogen itself, or it could be the body's own inflammatory response to the infection causing that interstitial damage.
Okay, so essentially the immune system mounts an attack on the interstitial tissue surrounding the tubules. Now, given this process and the varied causes, if someone presents with symptoms that might be AIN, what else should we be thinking about? What's on that differential diagnosis list from the notes?
This is a really important list for clinical practice, definitely one to have in mind. The notes outline conditions that can mimic interstitial nephritis and need to be considered.
Sure.
This includes other major causes of acute kidney injury, like acute tubular necrosis, ATN.
Right, ATN is a really common one in AKI, often from lack of blood flow or toxins, but it affects the tubules differently, doesn't it?
It does, yeah. Different mechanism, different pathology usually. What else is listed? Glomerulonephritis is there again.
Yes, highlighting again the need to know which part of the kidney is primarily affected.
Exactly. Urinary tract obstruction is also listed, even, a mechanical blockage affecting urine flow.
Okay, and some more systemic or structural issues too.
Yes, renal tumors are on the list, and also systemic diseases that might affect the kidneys more broadly. This list is pretty critical because the presentation can overlap quite a bit, and you really need investigations to help differentiate AIN from these other potential causes.
Understood. Now let's talk numbers briefly. How common is AIN, especially in the UK, according to this source material?
Well, the notes are quite upfront here. They basically state that the precise epidemiology of interstitial nephritis in the UK is not readily available.
Ah, okay. So no hard numbers from this source for the UK.
No, there isn't a specific prevalence or incidence figure for the UK to latch onto for revision from these notes. That's a key point itself, I suppose.
Yeah, good to know it's not known, too.
Exactly. What the notes do say is that it can affect people of all ages, and that the incidence and prevalence do vary depending on the underlying cause.
Right.
So, for instance, if a new medication known to cause AIN becomes widely prescribed, you might potentially see a local increase in cases linked specifically to that drug.
Makes sense. So the numbers might be elusive, but what does AIN actually look like in a patient? What are the clinical features the notes emphasize?
This is where it gets really clinical, yeah.
Mm-hmm.
AIN typically presents acutely so, relatively suddenly, with a decline in kidney function. The notes list classic signs like fever, rash, eosinophilia, and flank pain.
Okay, so that's the classic hypersensitivity triad you hear about: fever, rash, eosinophilia.
But here's one of those really high-yield nuggets from the notes, crucial for your revision. While that triad can occur,
Yes.
the notes state that the classic hypersensitivity triad of fever, rash, and eosinophilia is actually rare in AIN presentations.
Rare. That's really important. So you absolutely cannot rely on seeing all three to suspect AIM.
Precisely. It's maybe a bit counterintuitive if you learn the triad first, but it's vital to remember for exams and practice. Don't hang your hat on the triad alone.
Okay, so what are the more typical presentations listed then?
Well, the notes mention things like painless hematuria, sterile pyuria, so white cells in the urine, but no actual infection rash, and fever.
Individually, perhaps, more often than all together.
It seems to be the implication. Other common features listed include reduced urine output, fluid retention, protein in the urine, protein area, and high blood pressure, hypertension.
And I remember the notes briefly contrasted this with chronic tubulointerstitial nephritis presentations.
Yes, just briefly. They note that unlike the acute presentation of AIN, CTIN tends to present more insidiously with symptoms of chronic kidney disease over time. It's often linked to long-term analgesic use and typically seen in an older age range, maybe 30-70.
Right, but our focus is the acute picture.
Exactly. And don't forget that slightly surprising point the notes make. AIN may be asymptomatic in some cases.
Asymptomatic AIN causing AKI. Wow, that really drives home the point about needing a high index of suspicion, doesn't it? Especially if you're just looking at someone's kidney function tests and seeing a rise, particularly if there's been a recent change in medication history.
Absolutely.
So, if we do suspect AIN based on the presentation or the risk factors, how do we investigate it according to these notes? What tests should we be ordering?
The investigations usually start with some basic tests to look for clues. Urine analysis is key.
What are we looking for in the urine?
You'll look for white blood cells, red blood cells, and importantly, for eosinophils in the urine sediment, eosinophilluria.
Eosinophils in the urine, right.
Right.
And blood tests.
Blood tests are essential, obviously, to assess the degree of kidney injury, so checking creatinine and urea. You'll also look at the blood count for eosinophilia, elevated eosinophils in the blood itself.
Okay.
And sometimes liver enzymes like ALT, especially due to suspected drug cause, as the note suggests, concurrent liver involvement can sometimes occur with drug reactions.
Right. What about imaging? Do we need scans?
Renal imaging, usually an ultrasound, is generally helpful. It lets you visualize the kidney structure, check the size, and crucially, it helps rule out a urinary tract obstruction, which was on our differential list, remember?
Yeah, good point. Rule out obstruction. And what's the definitive test mentioned in the notes, the one that confirms it?
The source material points to renal biopsy as the way to definitively confirm the diagnosis and also assess the extent of the damage.
The gold standard.
Pretty much. But the notes do say this is used in certain cases. It's not necessarily the very first test everyone gets, but it is diagnostic when you need to be absolutely sure or understand the severity better.
Okay, so we've covered what it is, why it happens, who gets it, what it looks like, and how to investigate. Now, the crucial part. How do we manage acute interstitial nephritis based on these revision notes? The material divides management into prescribing and non-prescribing approaches.
Right. And the absolute most critical first step, particularly if a drug is suspected as the cause, which, as we said, it often is to identify and discontinue the causative agent.
Stop the drug.
Stop the drug. The notes are very clear. Renal function usually improves upon withdrawing the offending drug. This is probably the single highest yield point for management you need to remember.
Okay. Priority number one.
Definitely. They also specifically note that NSAID use as the cause tends to predict a worse prognosis, which is interesting.
Good to know. So stop the drug is the priority. What if it's not drug-induced? Say it's an infection.
Well, if an infection or another underlying disorder is the cause, then obviously treating that specific condition becomes the primary management strategy.
Makes sense. Treat the root cause.
Exactly. The notes also discuss the use of corticosteroids, like high-dose prednisolone.
Ah, steroids. Are they always used?
The phrasing in the notes is important here. They say steroids may aid recovery. The word may is key. It seems particularly considered in autoimmune or allergic type cases.
So steroids are an option, potentially beneficial, especially in those immune-driven causes, but maybe not automatic.
That seems to be the implication for these notes, yes. For managing blood pressure, which can often be high in AIN, the notes recommend antihypertensives, and they specifically mention ACE inhibitors, or ARBs.
Okay, standard blood pressure meds.
Yeah.
But with a very important caveat, I imagine, given the context of kidney issues and medications.
Absolutely. The notes clearly state to avoid ACE inhibitors and ARBs during pregnancy. That's a standard warning, but important here.
Right.
They also just briefly add that management for the chronic form, CTIN, is similar in principle, removing the causative agent or treating the underlying issue.
Okay. And on the non-prescribing side of management, what else is mentioned?
Well, if the kidney failure is severe, dialysis might be necessary, at least temporarily.
Right. Supportive care?
Exactly. If chronic damage occurs, leading to end-stage CKD, then transplantation could be required down the line. And of course, regular monitoring of kidney function is essential throughout the acute phase and afterwards.
And lifestyle.
Yeah, for managing any associated hypertension, the standard lifestyle modifications are mentioned. Exercise, weight control, reducing salt intake.
The notes also briefly touch on the difference between initial steps in primary versus secondary care, didn't they?
They did, yeah, just briefly. In primary care, the focus is really on recognizing potential kidney issues, taking a thorough history, checking BP for hypertension, looking for signs like swelling or edema, and doing a urine dipstick test for blood and protein.
The basics.
Right. And if you suspect an acute nephritic syndrome, which could include AIN, then prompt referral to secondary care is indicated.
And then secondary care takes over.
Yeah, secondary care then focuses on really pinpointing the exact cause and the severity,
Yeah.
which then guides the specific management approach we've just been discussing, stopping drugs, considering steroids, managing complications, and so on.
All right, moving towards the end of our deep dive into these notes then. What's the overall outlook, the prognosis for AIN?
So the source material states that the prognosis really depends on several factors: how severe the AIN is when it's diagnosed, what the underlying cause is, and crucially, how timely the treatment is initiated.
So getting to the cause and treating it quickly makes a big difference. Is that the main message?
Yes, absolutely. The notes highlight that prompt recognition and appropriate treatment can lead to renal function recovery in many cases. So that's a positive message, definitely.
Good.
However, they also include a warning. Some cases may unfortunately progress to chronic kidney disease, CKD.
Ah, okay. So not always a full recovery.
No, not always, which means long-term monitoring could be necessary for some patients. So while recovery is common with timely action, long-term kidney problems are definitely a potential outcome you need to be aware of.
And that leads us naturally to the potential complications then. What are the main problems listed in the notes if AIN isn't treated effectively or if it does progress?
Well, the primary complications noted are, as you'd expect, progression to chronic kidney disease, CKD, and potentially kidney failure, which could then necessitate ongoing dialysis or even eventually a kidney transplant.
Right, the serious long-term consequences.
Exactly. And other issues related to kidney damage. Electrolyte imbalances are mentioned as a common problem with impaired kidney function.
Okay.
And of course, there can be complications related specifically to the underlying cause itself. So if it was due to a severe infection or an autoimmune disease, managing those aspects is also crucial.
And the notes end this section with a pretty clear statement on how to avoid these bad outcomes, right?
They do. They really emphasize that early recognition and intervention are crucial to mitigate these potential complications.
Yeah.
That really brings everything we've discussed together. Spotting it early, identifying the cause, particularly stopping offending drugs, and acting fast are absolutely key to getting a better outcome.
So we've journeyed through your revision notes on acute interstitial nephritis, defining it, exploring the causes, understanding the mechanism, considering other possibilities, outlining what to look for, how to investigate, how to manage, and the potential outcomes and complications. We've tried to pull out the key facts and insights directly from the material you provided.
Yeah, hopefully hitting all the essential points, highlighting them to make them easier to recall for your revision. From the surprising rarity of that classic triad to the absolute importance of stopping the causative drug.
Thinking about everything we've just covered now, especially the varied ways AIN can present, the fact it can sometimes be asymptomatic, the classic triad being rare, what's one key challenge this condition presents, maybe for someone trying to diagnose it or even just trying to revise it effectively?
That's a good question. I think reflecting on the notes, the challenge really lies in its sort of mimicry and its dependence on a good history. It doesn't always scream AI with that textbook triad, as we said.
Right.
It really requires a high index of suspicion, particularly when you see unexplained AKI pop up and there's any change in medication history or maybe signs of an underlying systemic issue. Remembering that it can be subtle and looking beyond just the most obvious signs is probably the biggest takeaway for effective revision and clinical practice, too. It's easy to miss if you're not thinking about it.
That's a great point. A high index of suspicion is key. Well, that wraps up our deep dive into acute interstitial nephritis based on these specific revision notes. Hopefully, breaking it down section by section like this, highlighting those key nuggets, makes the information much more manageable and memorable for you as you prepare.
Yeah, we focused on the high-yield facts needed for revision, drawing directly from the source material you provided. Definitely keep revisiting these points as you continue your studies.
Thanks for joining us on this deep dive.
And just a reminder, if you're looking for more resources as you prepare for your exams, remember to check out passthemsra.com.
And freemsra.com as well.
That's right, freemsra.com too. both great resources.
We really hope this deep dive helps make your revision a little bit easier. See you on the next one.